Again, I am going to present something about how to face a neuro case in the exams. Hope some PGs are here, or all PGs, postgraduates. Don't worry. And then problem here is what? When you face a case of neuro-ophthalmology, naturally you are getting some nervous. That's the most important thing. Like a squint also. But don't bother about that. All these things are very easiest subject in the whole world. Only glaucoma and all is not nothing. So neuro-ophthalmology, squint and all very easiest subject, one of the easiest subjects in the whole world. So never forget about that. It's like a mathematics. You can easily overcome that. See, as in any examination, they have got history. Visual loss, is it transient, or double vision is there, periocular pain is there. Then we have got visual loss when it's there. Everyone knows, you are supposed to write visual loss or diminished vision, gradual, sudden, like that you're going to write. But most important, sudden means what? What do you think about the sudden vision loss is there? Mostly what now? Ischemic problems. Something block is there. Suppose gradual is there, maybe something corneal problems. Like that you can think. You understand now? Even cataract also you can have a gradual loss of vision. So unilateral and bilateral, most important problem. Unilateral visual loss means usually a problem is up to chiasma, before chiasma. Whereas if it's a bilateral problem, starting from chiasma onwards both. Posteriorly, it's bilateral. And I got changing the exercise during exercise. Suppose the patient tells you, say, I take bath, my vision is getting reduced. What's the is called? Classical optic neuritis case, multiple sclerosis. Multiple sclerosis, that is called Ophthal sign. What is Ophthal sign? When you take bath or increased body temperature, the vision is further getting deteriorated. Now the question is what? Why do you get this? They will ask you. Your answer is, sir, when you take exercise or something, the body temperature is increasing. Now there will be edema, the plaque is in the new demyelinating problems, they get edematous. They compress your optic nerve further. Number two, we have got so much of chemical substances are getting released. Environment is changed. There's a conduction delay. That's all you're supposed to tell in the exam. The reason for Ophthal sign. Transient loss. Transient loss lasting for a few seconds. Never forget about intracranial pressure increase. Papilledema patients. They will ask you why in papilledema you got a transient loss. Very simple. Whenever there is a raised intracranial pressure, there will be spasm of the ophthalmic artery or the posterior cerebral artery. So naturally the blood supply to my visual cortex is reduced. That's why transient loss is there. That's why papilledema patient can have transient loss. Whereas suppose the same transient loss lasting for a few minutes, never forget migraine. These two things, just transient loss lasting for a few seconds, then a few minutes. Never, as an ophthalmologist, never forget, transient loss can also occur in a case of previous attacks of angle koshak glaucomas. That's the most important thing. Transient loss of vision can occur in glaucoma patients also. Double vision, just to close one eye and see. Double vision disappears. That's called binocular diplopia. Only when both eyes are open, diplopia is there. When one eye closed, diplopia disappears. It's a case of neurology problems, neuro-ophthalmology problems. When I close one eye, the diplopia persists an ocular problem. That's all. It's very simple. That means when you close one eye, diplopia disappears means the problem is starting for us. You have to investigate further. When you have a closing one eye, diplopia disappears means problem. When disappear persists means a uniocular, maybe an ocular problem like subluxated. So many things are there, lenses and all. These are the commons you are supposed to know. Fluctuating, suppose the patient tells you, sir, I'm having morning diplopia, evening no diplopia. Never forget myasthenia. You know one important point? As a PG, suppose you are not able to come to a conclusion for anything. You are not able to come to any disease, something, diagnosis. Tell in the exams, sir, I want to rule out myasthenia. Finished. Don't bother. You can tell straight away. Suppose you are not able to come to a conclusion, you tell, sir, I want to rule out myasthenia, but you should know how to rule out. That's the most important. Understand now? You should know what is neostigmine test, so many things you are supposed to know. Then pain and movements, classically optic neuritis case, irritable neuritis case, they can have what's called Whitnall hypothesis, that's called Whitnall. That means optic neuritis inflammation is there, the dura mater is there of the superior rectus and middle rectus. When the optic nerve, when the muscle contracts, optic nerve is pulled, experience pain. That's why in elevation adduction, person experiences pain in a case of optic neuritis. History of oscillopsia. Please remember, a patient got nystagmus from birth. He will not experience oscillopsia. He will not experience. Suppose nystagmus occurs acquired. Now, recently, he will definitely he experience oscillopsia. Means if the entire world environment is moving for him. Naturally, he will have what? Nausea, vomiting, so many nonsense. There's a problem. This is called oscilloptic. See now the world appears like this for the patient. Ptosis variable. Suppose ptosis patient there. Variability. Straight away tell myasthenia. That's all. Straight away tell myasthenia. Can you see now here? One patient is got. Now they have tested now neostigmine. The ptosis improves. Now patient comes to your outpatient department. He is having an hemiplegic gait. Think about Weber syndrome. And he is having ataxic gait. Maybe cerebral problems. And he is having a tremors and all. He is having midbrain problems. Benedict syndromes. Head posture. See head posture just by seeing right and left, tilt and all. You can tell which muscle is involved. Straight away you can tell. Suppose my right head is turned towards right side. My right lateral rectus or left middle rectus. Straight away you can tell. Chin is depressed. I know superior oblique. Chin is elevated. Superior rectus. Straight away you know that this muscle is involved. By seeing the patient, you can tell there is a problem with the patient. Understand now? Eye examination, never forget. I have seen students, you are an ophthalmologist, you are supposed to write vision first. When you are starting eye examination, of vision first. Don't write vision last and all. You will get confused in the exams. I have seen students missing taking visual acuity. Leads measurements of ptosis, Marcus gun phenomena, whether it is there or not, canal ptosis, patients, Marcus gun phenomena is there or not. You know what is inverse Marcus gun? Hello, PG, you know what is inverse Marcus gun? When you open the jaw, the lid is normally opening, here it is closing. This is the Marcus gun. You see now, opening the jaw, the lid is opening up. When you open the jaw, the lid is coming down. It's called what? I don't want to ask Niranjan. Hello, Niranjan is a quiz master. It is called as Amerine-Amott phenomena. Amerine-Amott phenomena. Movements you are supposed to know, all the movements you are supposed to examine, pursuit, saccadics and all. Adduction, when you do right and left gaze, you see the eye is adducting or not, problem is there or not. Abducting gaze shows nystagmus or not. That means you are dealing with a case of internuclear ophthalmoplegia, that's all. Right side internuclear ophthalmoplegia means right eye adduction problem. Left eye means left eye adduction problem. Other eye will show nystagmus. Can you see here? Right eye is not adducting, left eye is showing nystagmus. This is called right side internuclear ophthalmoplegia. And of course, when you examine, always when you see the movements and all, see the position of lids. Otherwise, you will miss the Duane syndrome. Hey, you know one thing, never hold the lid and see the movements. If you hold the lid and see the movement, you are going liable to miss. Just see and like that left, that's all. Don't hold the lid and see. If a ptosis case is there, don't hold and see. You will have problems. So always see as such. Don't hold the lid and see the movements. You are liable to miss so many things. Up case, same thing. You see, it's called retraction nystagmus can occur sometimes when you move two movements, they can have retraction. That's all midbrain problems. Cover test and non-cover test you are supposed to know. Can you see now? Right eye deviated. You are covering left eye. The right eye comes and takes a fixation. Now, understand now, the left eye, you are like this, These are all you cannot coming under strabismus cases. But never forget, paralytic squint also you are supposed to do cover test and all uncover test. You are supposed to know primary deviations, second deviations. Like this, all these things you are supposed to know. Sensations, pupil, never forget about pupil. Pupil is your hello. Unless you examine pupil, you are finished. Can I ask one question before me finishing? What is the size of pupil during sleep? Any PG can answer. During sleep, what's the size of pupil? Because the time is running. Hello. Hey, dark room, man, you are sleeping. You tell something. Please remember, don't take dark room and all. When you sleep, the sympathetic system is knocked off. Sympathetic controls your dilator muscles. So only the parasympathetic is working. During sleeping, it is constricted, wherever you sleep. Number 2, death time. Death. When a patient dies, what's the pupil size? You always tell what? Dilated? Dilated only, you are measuring people alone. Dilated? Only 1 minute. Hello. Dilated? Now you see, we'll ask you, morning 8 o'clock, patient is dead. Now night, 8 o'clock, what's the people? Night time when you go and see him, is it rigor mortis? He will have rigor mortis. Now the rigor mortis, all the muscle contracting. What about the people will ask you? Never forget, pupil is what? Involuntary muscles. Rigor mortis affects all the muscles. That means the pupil constrictor muscle is powerful. Pupil is constricted during rigor mortis. Never forget this point. Pupil is constricted during rigor mortis. That time, when you suppose you go and see the patient, that time, don't tell he's alive. Please remember, he's dead.